Today we are going to discuss woman wants to be pregnant. After shaking the hand of the patient and introducing yourself, you will start to take the data of the patient about what is her name, how old is she, and then what is her nationality and what is her social status and what is the pregnancy history before, and if she was using her method of contraception or not, and what is her blood group, and what is her Rh typing, and what is her occupation, and where they live, her address, and then if she is alcohol take or smoker or addict, how many cigarettes she is smoking per day, and for how many years she is smoking. Patient complains she is who wants to be pregnant, or no pregnancy since she stopped contraception, or no pregnancy since the last delivery, or no pregnancy since last abortion, or no pregnancy since that operations, diagnostic curettage or laparoscopy or cesarean section, no pregnancy since marriage. And the duration of this is 1 year or 2 years or 4 years or more than 5 years. And then we ask about the menstrual history, the age of monarch, and the last menstrual date, and her cycle is regular or irregular. If the cycle is regular, the length of the cycle, and the length of the period, for how many days, and how many napkins she is changing per day, and the dysmenorrhea or not. If the cycle is irregular, it comes of how many months, and the duration lasts for how many days, and the amount of the bleeding, how many napkins she's choosing per day, is her shitties or not, her in the face or her in chin, or there is milk discharge from the breast or not. If the patient has regular cycle, she has mood change, premenstrual tensions, or she has headache, or abdominal bloating, or breast heaviness. She has a vaginal discharge after mucus discharge happens several days after days and become viscid. And sexual history, how many times per week, and she feels pain during sexual intercourse or not, and she deposits the semen inside the vagina, or semen regurg after finish, or semen deposited within a short time, or ejaculation before reaching the vagina, and there's problem of no erection, no desire, or she doesn't not like, or she wants to escape all the time, or there's superficial dyspareunia, or deep dyspareunia, or dyspareunia all the time of the act. We ask about the statistic history to see that she has ectopic or postpartum fever or postpartum hemorrhage, and we can analyze the outcome of each pregnancy, when this pregnancy occurred, which year, and how long it lasts, and any pregnancy problem, and the pregnancy ends in abortion or delivery. If it ends in delivery, cesarean section or vagina or forceps, the newborn male or female, how many kilos, and any postpartum complications, and any neonatal complication, and breastfed or not. Have been treated for lower abdominal pain and vaginal discharge, if she has been treated when and how long, and what is the medication she is using, because this may reflect that the patient has pelvic inflammatory disease. She has a fever and enlargement of the parotid or not. She wasn't using method of contraception, and what is the type of contraception she was using and when she stopped the method of contraceptions. She has diabetes. This diabetes controlled or not controlled for many years. She has thyroid problems. She has pelvic surgery, cervical cauterization, diagnostic curettage, evacuation curettage, aspiration of ovarian cyst, ovarian retrieval, and embryo transfer, artificial insemination. She has any abdominal operations, laparoscope, cesarean section, myomectomy, ovarian cystectomy, appendectomy, salpingolysis, salpingectomy, and bladder stone or laparotomy. She has inner problem. She has increased frequency and dysuria or burning micturations, and she has juvenile diabetes, adult onset diabetes, congenital disease or rheumatic heart disease or disease. What's the history? And the history of investigations. What is the FSH and LH? FSH is more than LH is good in second day. FSH more than 15, this is low ovarian reserve. Or if FSH is less than LH, and this is suspicious of ovarian problem. The prolactin is normal or elevated. High progesterone in the second half of the second cycle is normal and ovulating or not ovulating, and the serum estrogen is hypoestrogenic, hypogonadism is normal. Ultrasound of the uterus is normal and normally endometrial thickness, or there's fibroid, and ovaries is normal, or there's polycystic ovary or sugar cyst or poor responding to ovarian follicles, and next is normal or normal swelling or peritoneal cyst, or salpingograph is normal, or the uterine septum or unicondylar uterus or uterine synecia, and the laparoscope is normal, or there's laparoscopic ovarian drilling or hemolysis or falciation of endometriosis, ovarian cystectomy or myomectomy, and history of treatment of ovarian stimulation, laparoscopic ovarian drilling, myomectomy, artificial insemination, ovarian stimulation, ovarian retrieval, fertilization, and embryo transfer. Because sometimes the patient may come to you after trying to do several things, and any medication she is using, she is using ovarian stimulation drug to stop milk discharge or treatment of endometriosis. And we are asked us about the husband work. Working in chemical pollution or high temperature field, and if she has another wife, she has children, and when these children, the last age of the last children, if she is using any medications or not, or has surgery for vasodilatations or herniorrhaphy, and so. Data, pulse, blood pressures, and temperature, and face, there's hair in the face or not, and neck, there's thyroid enlargement or not, and breast, there's milk discharge and breast development or not. Then we'll do abdominal examination. We do abdominal examination. The hair distribution is no hair requires just to the mons pubis or extend to umbilicus, and there is tendon on the iliac fossa, or uterus is felt by abdomen, or tender swelling on one of the iliac fossa, or unilateral ovarian swelling or bilateral ovarian swelling, tendons in both iliac fossa, tender swelling on both iliac fossa, bluish nodule on cesarean section. Then we should vaginal examination, we do inspections for bleeding cervix, there's mucus and mucopurulent discharge, and then cervical cervix, there is normal cervical erosion or cervical ectropion, position follicle, cervical polyp or uterine polyps, and do digital examination. The cervix is firm, no tenderness moving the cervix is firm, and tenderness moving the cervix soft, general also open and cervical and cervical canal. And do bimanual examination to assess the uterus. The uterus is normal size of 6 weeks or bulky, or the symmetrical enlarged uterus or asymmetrical enlarged uterus. There's fibroids, there's cervical fibroid or broad ligamentary fibroid. Then we do examination of the bimanual adnexa. The adnexa is normal or bilateral polycystic ovary fullness of both adnexa, and tendons of right adnexa or tendons of left adnexa, or tendons of both adnexa, and tender swelling on right adnexa, tender swelling of left adnexa, bilateral tendon adnexal swelling, right ovarian cyst or left ovarian cyst. And then we do examination of the Douglas pouch. The Douglas pouch is free or boogie mass in Douglas pouch, or tender nodules on Douglas pouch, or tenderness on Douglas pouch, on ovaries are filtered in Douglas pouch, or pursue wall fibroid or ovarian cyst.